Hi, I'm Dr. Aliabadi. If you struggle with irregular cycles, acne, facial hair, body hair loss, or insulin resistance, you might be dealing with PCOS, or polycystic ovarian syndrome. Having dedicated my life to helping women with PCOS, I understand the challenges in getting an accurate diagnosis and the right care. That's why I created OV. OV is designed to help you take control of your health with clinically proven, validated ingredients in a simple, once-a-day solution. For too long, women with PCOS have had to choose between lifelong prescriptions or complicated supplement regimens. OV offers a better way to help manage your symptoms without the hassle. It's my mission to empower women facing PCOS and other hormonal issues by providing the information and support they need. Reclaim your health once and for all. Go to OV.com. That's OVII.com and start today.
Hi, I'm Mary Alice Haney.
And I'm Dr. Thais Aliabadi.
On this episode, our guest is Dr. Heather Jeffcoat, an expert on painful sex and pelvic floor disorders, something I didn't know much about before this talk. Dr. Jeffcoat is the author of Sex Without Pain, a treatment guide to the sex life you deserve, which is a must-read for women who have been looking for relief.
When I first met Heather, I was so impressed with her knowledge of medicine. Treating endometriosis is one of my biggest passions in life, and I always recommend combining this type of therapy to help treat any chronic pain.
Heather, thank you so much for being here today. We're going to talk about things that I didn't really know anything about. And when Dr. A said she wanted to have you in the podcast, I was really excited. I mean, I think that we talk about painful sex, we talk about painful periods are not normal, but I don't really know a lot, and I'm sure our listeners don't either, about pelvic floor dysfunction and how all of these are a part of that and how to treat them and what to look out for. So can you start by just kind of telling us what is pelvic floor dysfunction?
Sure. So it's when the pelvic floor muscles aren't working properly, and it can create like a whole mess of various symptoms that affect bowel, bladder, and sexual function. We're talking things like incontinence, bladder urgency, frequency, bowel issues like bowel incontinence, constipation, sexual function. So painful sex, inability to have sex, even sometimes inability to use a tampon. Because there's so much spasm or pain in the area.
I think the way I look at it is you either have symptoms before childbirth that are completely different than symptoms after childbirth. Before childbirth, patients have problems with penetration, painful sex, painful periods, which, you always have to think endometriosis when you do that. But post delivery is pelvic relaxation, when everything starts loosening up after a vaginal birth. And these are patients who also need physical or pelvic floor therapy. So why don't we start with younger girls and go through the spectrum?
Yeah. Because that's such a broad spectrum.
Yeah, so I see women all ages. I've had really young girls, actually. My youngest, I've had endometriosis patients that are 12 or 13. Painful periods, often one of the primary symptoms. They usually have a lot of like bowel or gut issues, usually constipation. And they're having pain and they're missing school. That's like one of the big early signs is missing school. When it gets undiagnosed later, they're missing days of work. Sometimes they're very sick, even like nausea, like all these other autonomic symptoms that they'll have with their monthly cycle.
And so what do you do? Like, how do you help them? What are the treatments?
Yeah, so from a physical therapy approach, I'm looking at trying to get their nervous system a little bit more calm, for one, because the more more ramped up they get, the more that feeds into their pain cycle. But endometriosis lesions that are similar to the lining of the uterus that's found outside of the uterus can lead to scar tissue. And so we're doing abdominal muscle relaxation techniques, fascial techniques over the abdomen to help mobilize the fascia around the organs to help reduce like strain in the area. So we'll mobilize that fascia over the ovaries, over the uterus, over the bowels, bladder, and that's all external when they're young girls. When they're older, generally at least 18, but sometimes 17 with parental consent and everyone understanding why we would do pelvic floor muscle work specifically, which would be internal intravaginal work. We're also checking for any muscle dysfunction in the area and treating what we find there.
I want to add something because, and endometriosis is one of my big passions in life. I think we talked about this at my office. I was so impressed when I met her because you have someone like her who's so educated on endometriosis and she's not a gynecologist, right? So I'm so proud of you. That's number one. Number two, if anyone's listening, I want them to know that besides pelvic floor therapy, endometriosis patients need to see their gynecologist and their lesions need to be suppressed. So the combination of what I do and what she offers is purely magic for these patients. And I want people to know that.
So I understand what you do for an endometriosis patient, but what do you do?
Yeah, so think like education, hands-on techniques over the abdomen, and intravaginal techniques for muscle relaxation, because these chronic pelvic pain disorders, which we've only mentioned endometriosis, but there's a whole bunch others we can talk about too. They are typically associated with a hypertonic pelvic floor, which means pelvic floor muscles that are sort of like always overactive or non-relaxing. So we do direct muscle techniques that are, the way I do them, I adapt them from traditional PT techniques. I've just adapted them to the pelvic floor muscles to get them to downtrain or relax and help reduce part of that pain cycle.
So when visually, are you putting your hands inside the vagina and massaging the muscles?
In very simple terms, essentially, but there are different techniques that are like really specific to the muscles that are overactive or hypertonic that we're doing. Concurrently, we're teaching breathing techniques. And also really important for me is I empower all of my patients to try to replicate what I do in the office at home. Because sometimes just seeing someone once a week might not be enough to get them out of their pain cycle, but the combination of an at-home therapy and what we do in the office can just be the difference of them being in pain or not pain.
And I can speak for endometriosis. A lot of endometriosis patients, especially in advanced stages, they do have scarring in the pelvis. Yeah. I did 2 patients today. They both had they had adhesions, and these adhesions tighten up your pelvic floor. So I can go in surgically, release those adhesions, take the endometriosis implants out, which is what I do every single Friday. And then I usually tend to suppress it with progesterone. But then I send my patients to her as a follow-up because most of these patients have had it for many years and they've gone undiagnosed, right? So their pelvic floor, I'm sure you see them all the time. It's so contracted. So I can fix it surgically and by giving them medication. But what she does, she helps relax those muscles, if that makes sense. Because even after surgery, you can have that tightness and that inflammation. So combining my world with hers makes a huge difference.
So it's, when I'm thinking about it, it's like you hurt your back. And you go to a masseuse or a physical therapist to work out whatever that is. You're doing the same thing in your pelvic floor. Can I even go a little bit more basic?
Yeah.
Your pelvis. So when I think of my pelvis, I think of like above my vagina, in between my hips. Is that like, where's my pelvic floor exactly? Is it like right here? Like, where is it?
Yeah, so the pelvis is a bowl, and then in the vaginal opening, the urethra, the anus, because we have 3 holes, which not everybody realizes, but those sit at the base, and then the floor is like a hammock that kind of think of it as like a circular hammock that supports your pelvic organs, your bowel, your bladder, and your uterus if you have one. And it also has like sphincter function, which means it helps like close and relax the openings. And it also has other functions like sexual function. It helps in orgasm and it actually helps support your posture too, which is why I think physical therapy is such a natural profession to be treating that, because it has a function with like supporting posture and helping with managing chronic hip and low back issues as well.
Can you talk to us about women who were sexually abused at a younger age? A lot of them have a very hard time having sex. For most of them, it's almost impossible because of that tightness. How do you manage these women?
Right, because having any internal work could be very traumatizing to them. So I think one thing that really helps in my office is we have really long appointments. So when I see a new patient, it's for 2 hours. And so there's a lot of discussion first, and there's like trust building. And then the evaluation that I do is in 2 parts. So the first part of the physical exam is just like any other orthopedic exam. Like if you're going for your back, like I'm looking at your posture, your range of motion, your muscle imbalances, and just how you move, things like that. It's a traditional orthopedic physical therapy exam. And then the second part, though, is a pelvic floor muscle exam. And what I do is I talk patients through every step of the way. I also don't have them in stirrups because that can be a little unsupportive and anxiety provoking for these patients. Right. And so we have them on like a big fluffy pillow, and their legs are supported on the pillow. And then I'm not using speculum. I'm using one glove finger. And I try to encourage them that my ring size is 5 3/4. I was meant to do this job. I have small fingers. So, and then it makes them laugh. So, it's getting them comfortable. And I will tell you, a lot of patients, because I've been doing this for 22 plus years, I have only had 3 patients my entire career that I have not been able to do an internal examination on, even though their GYN could never do it. So
with that painful sex, I mean, so what are the reasons for painful sex, and how do you fix it?
Yeah, there are so many possible reasons. So trauma, as Dr. Aliabadi alluded to, is definitely in some people's history. What I find commonly also, and is reported in the research, things like yeast infection history, even just one yeast infection. A lot of my patients have recurrent urinary tract infections or UTIs. Those are really common. It could be fell snowboarding, like hurt their tailbone, but some of your posterior or back pelvic floor muscles attached to your tailbone. So that can create like a cascade all the way that can eventually affect your vaginal muscles and create the inability to insert tampon or vibrators or have penetrative intercourse. And infection history, other than UTI as well, like any inflammation or pain in the area, broken bones, even a history of back pain. So actually, I had a patient who had scoliosis surgery in her teens, and was told to see a counselor because she couldn't have sex. It was painful for her, and nearly impossible almost every time. And I was asking her about her back history, and she was like, why do you keep asking me? I'm like, well, because there's a connection between your back and your abdominal muscles and your pelvic floor, so this is why I ask these questions. And she had told me that she had been to counseling for 15 years about her inability to have sex, and I was having her use these devices called medical dilators that help with are part of the home program that I teach people. And within a couple months, she was having sex.
Is that what these things that look like vibrators? So this is
She's going to steal them.
I can't wait. We never have props.
Give us, I want to put this in one of them in my waiting room.
Yeah, take them all. I brought them all straight.
I just need one.
For sure.
Because I want to put it in my waiting room. This is a big problem.
Yeah.
No,
and there's so many reasons for it.
So tell me what this is. So somebody comes into you with painful sex, and how do you treat it?
I want to add one more thing. Anxiety.
Yes.
Anxiety plays a huge role, especially it could be cultural too. certain cultures, girls, from the minute they're born, their parents are telling them, close your legs, don't have sex. So they're so scared of having sex that they don't enjoy it when they start doing it. So I see a lot of it actually in certain cultures, very common. But on top of the list, for painful sex, I would also put anxiety. So if it's an underlying...
Well, if it hurts, it's going to make you anxious. I mean, it's sort of like the cyclical
you don't know which one started first.
Exactly.
Yes, thank you. And then also, even we keep talking about endometriosis, like there might be a medical condition that is undiagnosed for the past 15 years and dismissed, as it always is, that can be underlying their painful sex.
So I come into your office, I have painful sex, I haven't been able to have sex. What do you do? Tell me what this is.
Yes. So we do that. We do that whole history, like I said. So I talk to you a lot. We do that 2-part physical exam. And then while I'm doing the intravaginal assessment, I'm also treating you at the same time. And usually the first technique that I'll teach people and that I'll do in my own office is a trigger point release. So if anyone's had any body work and you find a knot, tell patients, I'm looking for a knot in your muscle, and it's probably going to be painful to you, and to me it's going to feel like really taut or rigid. And then I find that spot, and then I just hold it with a steady pressure as I talk to you, and I keep my steady pressure, and then I come back to the knot and I'm like, is that better, worse, or about the same? And almost every time they're like, it's a little better. Did you release your pressure? I'm like, no, I did not release my pressure. That was your muscle releasing. Can we move on to the next muscle? And I coordinate breathing before I move to the next muscle, and we just go through kind of mapping the muscles of the pelvic floor. And as we do this, I start talking to them about, is this something you think you might be able to do with yourself with the dilators? And I've usually brought a dilator out to show them what that is before.
That's what this is, a dilator.
These are dilators. These are medical devices that are used to do intravaginal muscle techniques. And then I give them a handout so they have supportive materials when they go home. And then I also tell them it's okay if it doesn't feel exactly how it feels when you're here. I also tell them it's going to be very frustrating because you have never done this before. The pelvic floor is a little bit more of this mystery area for people. So I just say, even if you're just in there poking around, that's better than doing nothing, because think of it as like a stretch. And, I always bring it back to orthopedic correlates, because these are orthopedic problems in the pelvic floor. We say it's like orthopedics in a cave, really. And
orthopedics in a cave. I love it.
And I did not make it up. I won't take credit for that, but it is something that I'll use a lot with patients. And, so the orthopedic correlate, while I'm doing that, is I'll reach up and I'll grab their neck and I'll say, like when someone just comes behind you and they just start rubbing your neck, and they're not a massage therapist, not a physical therapist. They don't know what they're doing, but you're like, oh, that kind of. But
you teach them, and so it's important. On this podcast that we want women at home to be able to do all the things that you're talking about. You have lots of great videos on your Instagram, and you have a book that you wrote as well. Now, can we talk about? Because I didn't have painful sex, but I did have, after I had so much trauma with 2 of my births, that I was terrified to have sex, because I was like,
I still can't understand.
I know, it was terrible. I didn't have Dr. A as my doctor.
Oh my God.
But so a woman goes through birth, and obviously there's trauma that happens down there.
Yes.
So then what do you do? Or is it the same process?
So it's a similar process, but with a vaginal delivery, they might have scar tissue now as another reason for their pain. So in addition to the assessment and seeing if there's a muscle reason, it could be a scar tissue reason, but you can speak more to the hormones as well. But there's a complete change in hormone status after delivery that
Very
contributes.
good point. So postpartum, especially while women are breastfeeding, even when we do a pap smear, the pap smear comes back atrophic, just like a pap smear of a postmenopausal woman. Vaginal dryness is a big issue right after delivery, and it can last for up to a year. So I always, as long as you tell patients and they know that that's normal, you can have a C-section and have painful sex, by the way, when you first start having sex. But with vaginal birth, you have to be careful, especially when you get an episiotomy or if you have a laceration and they sew it up. Sometimes it tends to be a little bit tighter. Sometimes patients have granulation tissue. I had a patient, and that's a good example. She came postpartum. So this patient was delivered, and she kept having pain. She couldn't sit for almost 3.5 months post-delivery. And she kept going to her doctor, and the doctor was like, it's going to get better. It's going to get better. It's going to get better. She came to me, I think 4 months postpartum, in tears, because she's like, I can't function. It's disrupting my life. I can't sit. I can't walk. Before I even touched her, I knew she had granulation tissue. I don't know if you know what granulation tissue is. So anytime you close a wound, sometimes that overhealing produces a tissue called granulation tissue. But it's red and it's friable. And when you touch it, it's very tender. And usually it's tiny, but it's very tender. So before I even touched her, I'm like, oh, I know what you have. I can fix it. And she's like, what do you mean? I'm like, no, I know what you have. Let me double check. Let me make sure I'm right. So of course she had granulation tissue, and I use this these sticks called silver nitrate that burns it. It's almost, you won't feel it. It's very light. Within 1 session, her pain went away forever.
Wow.
So postpartum is a tricky situation. This is not an issue you see in a young girl, but postpartum women, whenever they have pain and they have a laceration, the first thing you want to check is is the opening too small? Did they over suture her? How's the scarring? Does it need, referral to pelvic floor therapy to massage the scar? Is there granulation tissue, or is it just postpartum hormone changes? And then you have to reassure them, tell them to use lubricants, and it will help them. Was that correct, Heather?
Oh, yes. Perfect.
And if she comes to you with scar tissue, how do you fix that?
So there's scar tissue techniques that we use. So they're just adapted to that region, similar like if someone has a like really thick or hypertrophic cesarean scar, or after they have knee surgery, they have a scar. Like we're using the same techniques. They're just adapted to the pelvic floor. It's a smaller area, a little more precise. Sometimes we might have to start with desensitizing it. So we might not be massaging it right away. We might give them something like a bumpy version of a dilator or vibrator, so that they can have a different sensation there that's not a pressure or a squeeze. So yeah, that would be one reason. But I did want to thank you for mentioning that even if you have a C-section, you can still have painful sex, which is true, but you can still have a lot of other pelvic floor dysfunction, because people are like, I had a C-section, I don't understand. But just being pregnant increases your risk of all these pelvic floor dysfunctions
because your pelvis goes like that, right?
And then we cut into it and all that inflammation, and you're in so much pain, and it's rough. It's rough what women go through. It's rough.
So what about incontinence with like urine?
Yeah.
Some people are constipated. Some people, have to go really quickly. And is that has to do with the pelvic floor too?
In part, but like the bowel stuff, often there's a dietary component, or sometimes they might have an infection. SIBO is a really common underlying, SIBO stands for small intestine bacterial overgrowth, for those that don't know what that is listening. But they can have, more medical components and dietary components, but sometimes they might lose their stool because they have pelvic floor muscle weakness. Sometimes they might be constipated because they have something called pelvic floor muscle dyssynergia, which is basically, think of it as when you think you're bearing down and relaxing, you're actually contracting. So your body is doing the opposite of what you think you're telling it to do. And you're essentially kind of kinking the hose back there. Like you can't.
So that's constipation.
That's constipation.
And so what do you tell somebody that comes in? What are you supposed to do in that situation?
So number one, are you using a toilet stool or a squatty potty? In like Asian cultures and like Eastern European cultures, they have those like toilets in the ground, right? And they're squatting. Like that is a better position for your pelvic floor.
By the way, I grew up in Iran, so sometimes like when I would go skiing, the bathrooms were just that.
Okay.
And those are not easy, by the way. You need to balance yourself. Your knees are cramping, and I was a little kid.
Yeah.
But you're saying that's how you should poop.
Well, so our toilets are not like that here. So what a company that, they're called Squatty Potty, they're kind of like world famous, I think. They popularized toilet stools. So it just brings you up so your knees are above your hips. And what that does, and it's been shown in studies, it changes the angle. It's called the anorectal angle. So it actually opens up that last part that needs to open before you poop. So it physically relaxes that area. And even like if you're traveling, you could like flip a trash can upside down and put your feet on a trash can, right? So the point is that your knees are above your hips, and everything's in a relaxed position. But if the muscles themselves are also tight and preventing, then yes, we also do intrarectal therapy. We go where the problem is.
Right.
And so
so you massage inside?
Yeah.
Okay. I've honestly never heard about this. I
Yeah.
cannot
Are
believe
you
it.
serious?
Never. I didn't even know that this was
But
something.
she's amazing. I mean, her knowledge of medicine is off the chart.
Like if someone's listening and they have painful periods, how do you know that they don't need to see an OBGYN or that they need to see you?
Well, they should see an OBGYN first.
Please start with your doctor. And if your doctor's dismissing you, go to another doctor. If your periods are painful, that's endometriosis until proven otherwise.
Okay.
Now you need a pelvic ultrasound. You need to make sure there are no fibroids, there are no ovarian cysts. You have to check everything. But I would start with a GYN exam. You should ask for a pelvic ultrasound just to make sure uterus, tubes, ovaries, everything's good. You want to make sure there's no infection, there's no bladder infection, there's no vaginal infection, uterine infection in the tubes, or PID, there's no chlamydia, gonorrhea, STDs. So you have to do the full workup.
Yes.
But unfortunately, majority of endometriosis patients still get dismissed even when they go to their doctor, and it takes 9 to 11 years to diagnose these patients. So I hope that when you're seeing these patients with painful periods, you're also telling them you probably have endometriosis.
So never on day one, because I have to develop trust. And that can be scary for them, because then they're going to go down the Google rabbit hole, and then they're going to think it's uncurable, and that they're going to be in pain the rest of their life and all of that. So, but I bring it up once I feel that trust is established. And I just always say, you know, it should be suspected. Has anybody ever talked to you about this?
Isn't that amazing?
Yeah. It really is. And I hear so much painful periods and I hear so much painful sex. You know, I hear that a lot, and people don't really know what to do about it.
What was so fantastic, ACOG, which is like the OBGYN Association for the US, finally, like a few years ago, put out the stat. It's on their website. Everybody Google it. 3 out of 4 women will have painful sex at some point in their lives. And yet my entire career, I've been met with OBGYNs, not you, others, that are like, my patients don't have that. And I'm like, how do your patients not have that?
1 in 4 women. So if you're hearing this, and
No, 3 in 4. 3 out of 4 will have painful sex at some point in their lives.
At some point, not always.
Yeah, not always.
At some point in their life.
And so when they come to you, this is about relaxation, and you teach them how to do this, and you have, tell all of our listeners they can read your book, and your book is Sex Without Pain.
Yes.
Perfect name, Sex Without Pain. And then where can they see how to use these amazing contraptions?
So I don't have a how-to video yet of how to use the dilator. It's the book. I have general education on Instagram. There's not like a lot of in-depth conversation I can have in 2 or 3 minutes on a reel, but telehealth, we certainly are available for that, as well as in-office sessions. Okay,
and if a woman has any of these issues that we're talking about, how do they find someone like you?
So there's also a national organization of pelvic health physical therapists. I was president of that, outgoing in February. It's called the Academy of Pelvic Health Physical Therapy. It gives you a directory of physical therapists across the U.S.
Are there any exercises you can do to strengthen your pelvis, like you strengthen your arm muscle, or Kegels? Is that for your pelvis too, or is there anything that women can do?
So Kegels are pelvic floor muscle contractions. So by doing a prescribed amount, you can get your muscle stronger. However, if you are in this category, which most patients that have pain in the pelvis are, they usually have the high tone or like a short, tight pelvic floor. So if you do a bunch of Kegels and your muscle's already short and tight, you could be making your pain worse, or at the very least not help it.
I want to quickly summarize. If you're sitting at home, painful sex could start from different parts of the pelvic floor and our pelvic organs. If you start from the outside, if you've never had pelvic pain and suddenly during sex you're having pain, then is it an infection on the outside? Let's start with the outside. Do you have a genital herpes infection? Sometimes that can affect, it can be very painful, it's ulcerated, it can make your sex very painful. then it can be a yeast infection. Patients with yeast infection often complain of dryness during sex. Oh, I don't know why, but suddenly it feels so dry in there. A lot of times that could be a yeast infection. So infection is the first thing you want to rule out. Then when you get into the vagina, from the skin outside, you get to the hymen. In young girls, very rarely, but it can happen, that these women have either very, very small hymens, which is the opening to the vagina, or they have imperforate hymens, which means there's a band, either vertical or horizontal, that was supposed to go away, but it never did. These are patients who cannot have penetration. Their complaint is usually, I can't put a tampon in. Something's blocking it. That's why it's important to have a very good pelvic exam. And you really have to, like she said, you have to insert your finger and make sure that there's not a band. If usually the vaginal issues are more for postmenopausal women, when you get vaginal dryness, or with postpartum women that just have had some hormonal changes that causes the vagina to be dry and makes sex painful. Then you get to the uterus, right? A lot of times, if you have fibroids on the uterus, it can make it painful. Endometriosis outside of the uterus. Endometriosis implants are on the uterosacral ligaments, the two ligaments that hold the uterus up, and behind the uterus in the posterior cul-de-sac. So if you have painful sex with deep penetration, chances are there's endometriosis implants sitting there. So like the two endometriosis cases I did today, both have painful sex, and both of them had these lesions in the posterior cul-de-sac, and I'm confident that when they have sex next time, the pain is gone. So that's another reason. Then you have to make sure there's no ovarian cysts, right? Because during sex, everything's really, it's not like your ovaries are up here. Our ovaries, uterus, and tubes are right.
They're all connected.
They're all connected, and they're right there in your lower pelvis. So sometimes if you have a big ovarian cyst and you're having sex and you're hitting it, it can cause discomfort. And these are patients who say, I have a right-sided pain, or I have a left-sided pain. Constipation can cause it. Sometimes patients have a retroverted uterus, where the uterus points posteriorly, and these patients sometimes tend to have more pain with sex. So you see, as a physician, that's why it's important to see a gynecologist, because you really have to start from outside and go all the way in. And that's why the pelvic ultrasound is also important, in addition to a pelvic exam. And check for cultures: urine culture, vaginal culture, sexually transmitted diseases. Sorry, Heather, I didn't want to hijack your
No, because you have to rule out all the medical.
Once everything's ruled out,
then it's anxiety, and it's muscle, and it's
trauma,
scar tissue, and all of that. But we have to start with the medicine first. So this is amazing. Heather, you are incredible. Thank you so much for being on the podcast today. I think this is going to help so many women. I never heard of this. And if I've never heard of this, and you're my partner, how is this possible? No, and I know so many women that suffer silently because women don't talk about it. And I think that that's just incredible. So we're going to have all the links to everything. Women should, after they've ruled out everything medically, then it's time to find a pelvic physical therapist, just like you would if you hurt your arm or your neck or your back. Your
and
vagina.
It makes all the difference.
Yeah.
All the difference.
Orthopedics in a cave.
Orthopedics in a cave, ladies. Thank you so much.
Thank you for having me. Thank you.
Thank you so much.
Thanks so much for joining us today on SheMD.
If you want to own your own health, a good place to start is by following us on social media at SheMD Podcast, and by subscribing to our show on YouTube or wherever you get your podcasts.
For takeaways from today's episode, visit our website, shemdpodcast.com. We'll see you next time on SheMD. This podcast is for educational and entertainment purposes only. It is not intended as a substitute for a physician's medical advice. You should regularly consult your medical provider in matters relating to your own health. Even though we share our honest beliefs on SheMD, some of the products and services we discuss may involve sponsorships or paid advertising.